Hi everyone, in this video we'll be talking about delirium. We'll discuss the approach to a patient with delirium, the definition of delirium, the causes, the risk factors, how to prevent, and the management. If you're interested, please keep on watching. So let's start with the definition of delirium. The American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders, 5th edition, the DSM-5, lists 5 key features that characterize delirium. The first one is disturbance in attention, which is reduced ability to direct, focus, sustain, and shift attention, and disturbance in awareness. The second feature is that this disturbance develops over a short period of time, usually hours to days, represents a change from baseline, and tends to fluctuate during the course of the day. The third point is there is an additional disturbance in cognition, which includes memory deficit, disorientation, language, visuospatial ability, or perception. The disturbances are also not better explained by another pre-existing, evolving, or established neurocognitive disorder, and do not occur in the context of severely reduced level of arousal such as coma. And finally, there is evidence from the history, physical examination, or laboratory findings that the disturbance is caused by a medical condition, substance intoxication, or withdrawal, or medication side effect. Additional features that may accompany delirium and confusion include the following: psychomotor behavioral disturbances such as hypoactivity, hyperactivity, with increased sympathetic activity and impairment in sleep duration and architecture. And there also could be variable emotional disturbances, including fear, depression, euphoria, or perplexity. So we can briefly define delirium as an acute deterioration of mental state characterized by fluctuating symptoms of impaired attention, cognition, and consciousness that are typically developing over hours to days. There are 3 types of delirium. There is the hypoactive delirium, where the patient is quiet and withdrawn. Hypoactive delirium is the most prevalent form of delirium, but is not as obvious and often missed. There is also the hyperactive delirium, where the patient has agitation, restlessness, hallucinations, or delusions. There is also a third type, which is mixed delirium, where the patient alternates between hyperactive and hypoactive states. Delirium can cause the patient and the family, carers, or significant others significant distress. In addition, compared to a patient of the same age, a patient with delirium is more likely to have a longer hospital stay, be admitted to a residential aged care facility, have a subsequent dementia diagnosis, fall, or die. The most important risk factors for delirium. The most commonly identified risk factors are underlying brain diseases, such as dementia, stroke, or Parkinson's disease. So this point is very important. The second one is advanced age 65 years or older. The third one is sensory impairment, such as auditory or visual impairments. Other predisposing risk factors are problem alcohol use, multiple comorbidities, a previous episode of delirium, and depression. There are also a lot of precipitating risk factors in adults. The most commonly reported precipitants of delirium include acute hip fracture, acute organ failure, cardiac events, critical illness, drugs, hyperthyroidism and hypothyroidism, infections, intracranial events, major surgery, metabolic disturbances, pain and discomfort, physical restraints, withdrawal states, and urinary catheterization and retention. Drugs are important factors in delirium. There are a lot of drugs that commonly cause or contribute to delirium. The most important ones are alcohol and illicit drugs such as cannabis and methamphetamine. The second very important category is anticholinergics. Drugs and drug groups with significant anticholinergic effects are some antipsychotics, atropine, benzatropine, and trihexyphenidyl, drugs for bladder overactivity, hyoscine, prochlorperazine, sedating antihistamines, and tricyclic antidepressants. There are also corticosteroids that can cause delirium, dopaminergic drugs such as levodopa, dopamine agonists, and others. Opioids can also cause delirium. Non-steroidal anti-inflammatory drugs, propranolol and sotalol, and psychotropics, especially benzodiazepines. Virtually any medical condition can precipitate delirium in a susceptible person. Multiple underlying conditions are often found. The conditions noted most commonly in prospective studies of the disorder include fluid and electrolyte disturbances, such as in dehydration, hyponatremia, and hypernatremia, infections, such as urinary tract infections, respiratory tract, skin, and soft tissue, drug or alcohol toxicity, withdrawal from alcohol, or withdrawal from barbiturates, benzodiazepines, and SSRIs. Metabolic disorders such as hypoglycemia, hyperglycemia, uremia, liver failure, and thyrotoxicosis. Low perfusion states, as in shock and heart failure. Post-operative states, especially in older adults. Regarding the diagnosis of delirium, there are tools to identify adults with acutely altered cognition include the 4AT test or the Confusion Assessment Method CAM and its variant. There is also the CAM-ICU and the 3D CAM. As for the investigations, a number of laboratory tests may be considered in the patient with delirium. The most important ones are serum electrolytes, creatinine, glucose, calcium, full blood count, urinalysis, and urine microscopy and culture. So these are the reasonable ones for most patients when a cause is not immediately obvious. Drug levels should be ordered when appropriate. However, clinicians must be aware that delirium can occur even with therapeutic levels of such agents such as digoxin, lithium, and quinidine. Toxic screen of blood and urine should be obtained from patients with acute delirium or confusion when a cause is not immediately obvious as well. Blood gas determination is often helpful. In hyperventilating patients, respiratory alkalosis is most commonly due to early sepsis, hepatic failure, early salicylate intoxication, or cardiopulmonary causes. A metabolic acidosis usually reflects uremia, diabetic ketoacidosis, lactic acidosis, late phases of sepsis, or salicylate intoxication or toxins, including methanol and ethylene glycol. A chest X-ray is usually performed as well. Further testing, such as liver function tests, should be based upon the history and clinical examination. A report of slow cognitive decline over several months, for example, will increase the importance of evaluating thyroid function and vitamin B12 levels. Other investigations to consider can be a brain CT, ECG, bladder ultrasound, cardiac enzymes, lumbar puncture, and an EEG in cases of altered consciousness. So now let's move on to the prevention of delirium. So no intervention or group of interventions reliably prevents delirium. However, multi-component, non-pharmacological interventions that manage many of the modifiable risk factors appear to reduce the incidence of delirium. So examples of interventions designed to mitigate risk factors for delirium include, the first one is orientation protocols, such as the provision of clocks, calendars, and windows with outside views, and verbally reorienting patients may mitigate confusion that results from disorientation in an unfamiliar environment. The second one is cognitive stimulation. Patients with cognitive impairment in particular may benefit from activities such as regular visits from family and friends. At the same time, sensory overstimulation should be avoided, particularly at night. The third one is facilitation of physiologic sleep. Nursing and medical procedures, including the administration of medications, should be avoided during sleeping hours when possible. Nighttime noise should also be reduced. Another important thing is early mobilization and minimized use of physical restraints for patients with limited mobility. We should also pay attention that visual and hearing aids are provided for patients with these impairments. Another very important measure is avoiding and/or monitoring the use of problematic medications. So medications are often implicated in precipitating delirium, particularly in those already at risk. Benzodiazepines in particular are often implicated. In one systematic review, the authors concluded that benzodiazepines should be avoided in high-risk patients, while caution should be used in prescribing opioids, dihydropyridines, and antihistamines. We can also make sure that we're avoiding and treating medical complications. A number of medical conditions are known to cause or aggravate delirium. These should be managed aggressively and prevented where possible. And finally, managing pain, which may be a significant risk factor for delirium, pain itself. So in patients who establish delirium, what do we do? So the first and most important thing is we should address the cause or causes of the delirium in the patient. Drugs are not required for most patients. We should also avoid using psychotropic to manage delirium. We should address its cause and causes, as I said, and use non-pharmacological interventions first. If a psychotropic is required because the patient is significantly distressed or considered a threat to themselves or others, we can administer an antipsychotic orally if possible. A single dose of an antipsychotic is usually adequate. We should also avoid using benzodiazepines, except for delirium caused by alcohol or benzodiazepine withdrawal or seizures. So regarding antipsychotics, despite the limitations of antipsychotic therapy, consider using the regimens below for an adult with delirium if they are significantly distressed or considered a threat to themselves or others. and addressing the cause or causes of delirium and using non-pharmacological measures have not calmed them. So for adults with delirium who do not have Parkinson's disease or dementia with Lewy bodies, we can use haloperidol 0.5 milligrams orally as a single dose. 1 milligram may be required for younger patients, or olanzapine 1.25 to 2.5 milligrams orally as a single dose. 5 milligrams may be required for younger patients, or risperidone 0.5 milligrams orally as a single dose. 1 milligram may be required for younger patients. For adults with delirium who have Parkinson's disease or dementia with Lewy bodies, we can use quetiapine 25 milligrams orally as a single dose. So the reason for that is haloperidol in particular and olanzapine and risperidone can aggravate motor features in Parkinson's disease or dementia with Lewy bodies. That's why we try to avoid them and we use quetiapine for these patients. And of course, if oral administration is not possible for adults with delirium who do not have Parkinson's disease or dementia, we can use the same doses of haloperidol and olanzapine intramuscularly. And if oral administration is not possible for adults with delirium who have Parkinson's disease or dementia with Lewy bodies, we should seek expert advice. So to summarize, if a patient is having delirium, the first thing we can do is review meds, take a focused history and physical, make sure we get the vital signs, and order some labs such as full blood count, electrolytes, urea and creatinine, glucose, urinalysis, and an ECG. And from this initial assessment, if we find an offending drug, we discontinue that drug. If there's a trauma or a focal finding, we consider CT brain. If there's a focus of infection, we should begin antibiotics. If there's an unexplained fever and a nuchal rigidity, consider lumbar puncture. If there's no obvious etiology, we can do further investigations such as B12, folate, thyroid function, EEG, MRI brain, drug levels, and toxin screen. And in the meantime, we can institute the supportive measures such as maintaining the hydration of the patient, avoiding restraints, mobilizing the patient, reducing noise, make an orienting stimuli, reassure the patient, provide a bedside sitter, and manage pain and treat the underlying medical condition that he's in the hospital with. And if the patient behavior interferes with care or safety, we should consider low-dose neuroleptic such as haloperidol or quetiapine as we discussed earlier. And that concludes this video. I hope it was helpful for you. Thank you very much for watching.